Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled The Advantages of the Ross Procedure. If I've yet to meet you, I'm a former Ross procedure patient, and I'm also the founder of HeartValveSurgery.com. The mission of HeartValveSurgery.com is to educate and empower patients with heart valve disease. And this webinar, which has had over 130 registrations from patients in countries all over the world, is designed to support that mission. So you know, during the webinar, all participants will be in listen-only mode. That being said, you may submit questions during the webinar. Simply post your questions in the control panel that's typically on the right side of your screen. We will do our best to address your questions during the Q&A section of the webinar. Lastly, at the end of the webinar, we ask that you complete a very, very quick 5-question survey about this event. Now, I am beyond thrilled to introduce the featured speaker of this webinar. Dr. Paul Stelzer is a professor of cardiothoracic surgery at Mount Sinai Hospital in New York City. Specific to the Ross procedure, Dr. Stelzer is one of the leading surgeons in the world, having completed over 530 Ross procedures. Personally, I've known Dr. Stelzer for several years now, and I could go on and on and on and on about this really incredible person. I could go on about his background, and I could go on about his achievements in cardiac surgery during his 32-year career. Instead, I will simply tell you that this man is absolutely loved and celebrated by the members of our community, some of which that you see here. Since launching this website in 2006, Dr. Stelzer has successfully treated many patients from this website, including Peter Woglum, Jeff Schabowski, Mark Croto, Clarissa Vasquez, Chris Dixon, and Debbie Raphael. I am humbled that Dr. Stelzer is taking time away from his very busy practice to educate all of us about this unique form of aortic valve replacement. So without further ado, I'd like to introduce all of you to Dr. Paul Stelzer.
Yes, thank you very much, Adam. It's a pleasure to be here with you, and hopefully we can talk a little bit about what the Ross is and why it is and what it might have to offer for people in 2013 and the future. Next. The basic anatomy of the heart is most beautifully described in some pictures that Frank Netter did many, many years ago. And this picture and the one following it shows you the structure of the 4 valves of the heart. They're all arranged pretty close to one another. The aortic valve is sort of right in the middle as the kingpin, and the pulmonic valve just above it. And this is when the heart is relaxing, filling through the mitral and tricuspid valves into the ventricles, and the semilunar valves, as we call them, the aortic and the pulmonary valves, are closed. In the next slide, you'll see what happens when the heart squeezes in what we call systole. The contraction phase of the heart opens those semilunar valves and closes the atrioventricular valves. This is when the blood is actually being pumped to the lungs from the pulmonary side and to the whole systemic circulation through the aortic valve. And as you see in these two pictures, the aortic and the pulmonary valves look just alike, and they're right next to each other. And that's what occurred to Donald Ross so many years ago about, what could be better than putting in a donor valve, which was the first thing that he did way back in 1962, but he wasn't sure how long that could last. So he said, well, this pulmonary valve is sitting over there right next door. Maybe I could move it over, make that the aortic valve, and put that potentially troublesome homograft in the right side of the heart where the pressures are lower and the consequences of failure are much less. So it kind of relates to this anatomy that you see so beautifully on these drawings by Netter. Next. And we're going to go through a lot of this stuff pretty quickly, and some of these slides I just want to tell you are in there so you can look them back up again when the slides are available in electronic form for you. But to review the basic anatomy is that the cardiac valves are all supposed to do a few things. that nothing we've made artificially can do to accomplish these particular elements of allowing blood to pass through them in just one-way valve, never going backwards, and never offering any obstruction to the forward flow, and without forming blood clots or damaging the blood or having a Mission Impossible self-destruct button. Next. The two basic problems that the aortic valve specifically gets into are stenosis and regurgitation, stickiness and leakiness, as we call it. And they produce different things as far as their impact on the heart. Stenosis produces a requirement for the heart to generate more pressure. And the leaky valve, the regurgitant valve, gives extra volume, fluid volume that you're supposed to get downstream and never come back, comes back into the heart. You have to do it again, so that the amount of blood that comes back is increased as the regurgitant fraction increases, and then you have to do that much more work. The heart responds to that by dilating, getting bigger and bigger over the course of time, where it responds to the pressure load by getting stronger, like lifting weights. We call that hypertrophy, the thickening of the muscle. And these numbers just kind of say how we qualify and quantitate that or semi-quantitate that on echo. Next. There are a lot of different causes. The most common one that we see in young people that might be candidates for the Ross procedure were born with a valve that wasn't formed exactly right. We call it built on a Monday kind of valve. And about 1 or 2% of the population actually has this. It's about 3 times more commonly seen in males than females. There are a couple of other causes which are less common, especially in the Western world. Rheumatic fever, still common in less developed countries. The kind of calcium deposits that come with age and cause degenerative changes in the aortic valve are more typical of the elderly population, who would be less candidates for this kind of surgery. Next. And the cardinal symptom that we see is patients who have short-windedness when they run up the stairs or try to climb too big a hill, and that's the most typical thing for a lot of valve diseases, particularly aortic and mitral disease. Chest pain happens to some people because the oxygen supply is outstripped by the oxygen demand. The heart muscle needs more oxygen to do more work, and even though the coronary arteries may be perfectly fine, if the amount of obstruction from aortic stenosis is severe, the heart just says, ouch, I can't do that. I'm not getting enough oxygen to do that work. And occasionally the pressure just can't be maintained and the patient will pass out. And that's not a good thing either. Next. So when do we decide it's time to fix it? Anyone who's developing these symptoms, and we can't blame it on anything else, we should operate on those people. There's something needs to be done about that. Why is that? Because that's when your life expectancy curve diverges from the normal population. You can have even severe aortic stenosis without any symptoms, and you can rock along with the same life expectancy as your neighbor who doesn't have that until you develop symptoms. Once you develop symptoms, 50% of patients die within 2 years. So that's a healthy risk if you don't do something about it. So that we kind of have to keep in the background compared to the risks of surgery, which are always present, but they're not 50%. There are also some signs on echo that trouble may be brewing, even though you feel great. And that's when the regurgitation side of the equation comes in more so than the stenosis. Because there, that subtle, insidious dilatation happens to the left ventricle and can weaken that muscle, ultimately to the point where it can't recover. And you're still feeling fine. So we really have to watch that on the echo. That doesn't mean we have to watch it every 2 months. It means once a year, every 6 months if you're getting close to the kind of numbers we worry about. We look at the pulmonary artery pressures in many forms of valve disease, because particularly with exercise, a rise in pulmonary artery pressure may indicate that the heart is just not able to keep up with the demands. It doesn't have what I call the functional reserve capacity that you want to have. Now, if you're just sitting around flipping channels on the remote, you're not going to be able to test that. So don't do that. Stay active. Stress test is a way of kind of putting you through your paces under our noses so that we can see what your heart does in response to exercise. And particularly with aortic stenosis, if your blood pressure doesn't go up, which it should do under exercise circumstances, if it goes down, that also is a sign that your heart's not able to keep up with the demand. Next. Well, can't we treat this valve with some kind of pill? Unfortunately, it's like having a faucet that's not working. You got to call the plumber. There is medical treatment that's available for regurgitation, and that can stall out the need for operating for a couple of years in some situations. But there really isn't anything that you can do to fix a valve that is opening. Balloon valvuloplasty, or putting a balloon through a valve and blowing it up, popping it open, is something that's used very commonly in very young children, infants. And that's been a real lifesaver for those kids. We used to have to operate on those people, even at birth. So we don't have to do that anymore. The balloon valvuloplasty has helped save those lives. And we can wait until they're older to fix them definitively. It's possible to do it in some young adults. It's been done in pregnancy, for instance. When stenosis has been discovered in a young woman, you can pop the balloon through that valve and get her through that pregnancy. But unfortunately, as the valve starts to calcify, the balloon valvuloplasty becomes very poor for durability numbers. It's extremely uncommon to get even a year out of it. It doesn't mean you can't do it again, but once you've done it a couple of times, the chances of turning a sticky valve into a very badly leaking valve is considerable. So that's just not a great option. Disappointing. Valve repair, which is coming more into the forefront these days for regurgitation, is certainly an option that we need to explore in the young patient as well. And that's an option. If the anatomy applies itself properly, we can get some pretty good long-term results. But stenosis repair is just not an option for. When those things are really bad in the adult, stenosis is not something that we can repair. Next. So the replacement reasons then are summarized on this slide, and we can just skip on to the next. And what do we have to choose from? Lots of things out there. There are mechanical devices, there's cows and pigs and even horses donating blood and valves to us. And on the bottom you see the stentless, which is a pig's aorta complete with its valve. In the middle, an aortic homograft, complete with its aorta and its arch. And the valve at the bottom end even has a little mitral attached. And in the far right-hand corner, down the bottom, you see the pulmonary autograft. That's someone's own native pulmonary valve. So thin you can see right through those leaflets there in the middle. Next. There have been some guidelines developed by the American Heart Association and American College of Cardiology over the years. These go back quite a while. And if you look at the guidelines for when you have to replace a valve, what kind of valve do you use? And most of you who are listening in on this are patients who are under the age of 60. And look what happens in that red circle at the top right. It looks pretty simple. If you have basically any reason to need a valve, you get a mechanical one. And occasionally, if they just don't think you're going to live very long, or there's some compelling reason not to be able to use anticoagulation, then you'll get a bioprosthetic biological valve. Next. Well, that was published way back in 2003. But look what was happening between that time and a decade before. People were following the guidelines back in the early 90s, but in spite of those guidelines being there, the percentage of mechanical valves dropped in half. Well, why do you suppose that happened? Next. Well, it's because a mechanical valve is not the walk in the park that we would love it to be. We used to tell patients, we put a mechanical valve, or metal valve we often used to call them, although they're virtually all just plastic nowadays. Put it in, you'll never need another operation. Yeah, you have to take blood thinners, but it's not a problem. Have a nice time. But here's what really happens, and that's there are a lot of people that don't have such a wonderful time. There are some undesirable events. The top part, valve-related deaths by 15 years, are about 10 to 15%. There's a little group of people who had to get reoperated on because they had infections. There's a group of patients who had thromboembolic phenomenon. That you probably heard about clots going places that we don't want them to go, or bleeding. And then there's another kind of unexplained category of other deaths. So that by the time you get to 15 years, less than a quarter of patients got off totally unscathed. And that's very humbling. Notice the numbers aren't too big when you look at that. The number of patients is on the bottom, just above the scale there. So we know it's not a walk in the park. There's just not a free lunch out there in terms of our choices. So these are the kind of things that made us think, well, mechanical valve isn't so great a solution, especially for active young people. Next. Well, what about the animal tissue alternatives? That technology is constantly getting better. We're in what we call third generation tissue technology now. Definitely more durability. What used to be a 7 to 12 year valve is now a 15 to 20 year valve, especially in the older patients where we have more data. How have we made them work better? By trying to fight against the tendency for all these valves to calcify over time. And there are different ways of doing that here. They're better in terms of the blood flow characteristics, but some of them you have to go to a lot of trouble to do it, like the root replacement technique with the stentless valves. Next. This is the real Achilles heel of the animal tissue valves, and that is that durability is inversely proportional to your age. And particularly when you're down less than 35, to see a valve that we think is going to last 15, 20 years but has to be taken out 6 years after you put in, that's not very good news. And the next slide shows how the data actually pan out for the different age groups. So if you're 65, at 15 years, the chances that you're going to have to take it out and do it over, looking at as ugly as it looks there in the top right-hand corner, is about 8%. But if you're 10 years younger than that, it's more than double that. If you're 40 years old, there's a 37% chance that you're going to have it taken out by 15 years. And you can see how the curves just keep going worse and worse the younger you get. Next. This is just another way of graphically demonstrating that durability is age-related. The different color curves relate to the chances of having to get another valve, essentially for structural valve degeneration is what SVD is talking about at the different age. And it just goes right down if you're 50, if you're 40, if you're 30, if you're 20. The chances of you're getting 15 years out of a valve at age 20 is only 20%. Next.
Hey, Dr. Stelzer, this is Adam. A quick question for you is, given what you're showing here about the age-related durability here, and this might be a silly question, is this just because the younger the patient is, the more active they are, the more requirements they have on cardiac function that ultimately wears through those tissue valves faster?
I think that's probably right, although it's very hard for us to prove that. When you think about it intuitively, an active young person puts a lot more volume of blood through that aortic valve every day than the older person that's more sedentary. And so you've got wear and tear on those moving parts every time the heart pumps stuff through. And if you're pumping 12 liters a minute through the valve when you're running versus 6 liters a minute when you're watching TV, you're going to put twice as much stress on those leaflets. And so I think that has something to do with it. There's also something in the very young that has to do with calcium metabolism in growing and maturing young people, and that may leave some of these valves much more susceptible to calcification at those very young ages.
Great, thank you.
Next, that's great. I've put a couple of slides in here that we can skip over for future reference, and this is just to kind of talk about. I'm not the only one that's looked at these questions of how do you make people live longer. Next, survival after valve replacement is not as good as we'd like it to be, and it's not as good as a patient who doesn't have aortic valve disease, who hasn't had an operation. And so we don't know exactly what that all is. Next. This is a way of saying it's not just age. It has something to do with the size of the valve that you put in. These Z values are related to kind of statistical models that talk about how many standard deviations are you off of normal. And you can see that if you're 55 years old, which isn't very old, but you get a valve in there that's 2 standard deviations or 2.5 off of what you really normally come with, then your life expectancy is that of an 80-year-old. That means a lot of years are cut off your life. So putting in a valve that's too small in a young person is a real bad thing to do. Next. Well, here's Donald Ross, the last time I visited with him a few years ago, and let's talk a little bit about what he came up with so many years ago. Next. Donald looked at that pulmonary valve right next to the aortic, as we saw in the Netter drawing, and said, let's see about moving that over. But you see one of the key differences in the picture of those little red pipes coming out the sides of the aortic valve. Those aren't present on the pulmonary valve. So if we move that over to the aortic position at some point, we have to accommodate those. The way Donald did it was he kind of took that valve off, complete with a little bit of the pulmonary artery, and then he stuck it down inside the aorta and scalloped a notch out of the two parts of that. He actually did all 3 at first. Then he said you don't have to do the 3rd one, to make room for the coronary artery to have blood flow. The way I started doing it was say, what if I just replace the whole root and reconnect the coronary arteries? And that way I don't have to distort the 3-dimensional geometry. Next. So his concept was to take that fully alive tissue from the patient's own pulmonary position into the workhorse side of the heart, and then put the homograft, as they say, the one that he didn't know what was going to happen to ultimately, into the side where trouble would be easier to fix and dysfunction would be tolerated much better. Next. This is a picture that was taken in the late 80s when I was out in Oklahoma with Ron Elkins, and he and I were the first really to do Donald's operation in the United States. We didn't call it a Ross operation back then. We call it a pulmonary autograft procedure. Next. Donald had actually started this way back in 1967. As I said, he put it on the inside. We call it a subcoronary implant, and then he said, let's try to maintain that 3-dimensional geometry and maintain its cylindrical shape. And then when Ron and I started doing it, we did the first few starting in the fall of 1986. I helped Ron do several of them with subcoronary implants. And then in 1987, when Ron was out of town one day, I did one as a full root replacement, implanting the coronaries. Next. And that basically is shown in these pictures from a publication from 1989. We actually presented these slides at the American Heart Association meeting in 1988, which shows the dismantling of the aortic roots and the pulmonary roots, the coronary arteries sitting up there like breakfast with the 2 eggs and the salt and pepper shaker, and putting it all back together again, starting with the root reconstruction on the right side. Next. This is a more modern drawing of that same concept where we open the aorta, take out the aortic valve, and then we dismantle the pulmonary from the right ventricular outflow tract with a little rim of muscle so that we've got something to sew to. Next. When we put that in, I like to support it with a strip of Teflon felt to keep that from bleeding and to keep it from stretching. You have to pick how you put it in there in a way that you see those little notches, what we call them, the commissures, are located, because the sinuses have room for the coronary arteries, but you don't want a coronary artery to end up right on the commissure. So you want to make sure you put that thing in a way that's going to fit properly as far as the coronaries are concerned. So the first step then, once we get it out, is to put it into the root and support it appropriately. Next. Now, when we do this kind of surgery, there's some assumptions about who should have it. And one of them is that you need to have at least a 20 to 25 year life expectancy. And that's why this is for young people. If we've got somebody who's 70 or 80 years old, we don't have to do this fancy an operation because they don't need it. They've got the enhanced durability of the animal tissue valves in their favor. And most of the time, those valves are going to outlive the patient. They're not going to outlive the young patient. The young patient's going to be faced with having it done again. So we want to try to get good function and good long durability without having more operations than you absolutely need. How do you get there? First, your ventricle has to be good. The left ventricular function is a major determinant of your life expectancy. So if that's normal, that's a great one. Dialysis is not a good thing in terms of life expectancy, for sure. So that's something that pretty well kicks you out of the category for a ROS. And coronary disease is not a contraindication, but if you're going to do a young man's valve operation, you better be able to do a young man's coronary operation, like a single left internal mammary artery graft to the left anterior descending. Complex congenital heart disease is a real problem, and that may not allow us to do this kind of surgery. So we want somebody who's got a potentially normal life expectancy to make it worth the while to do this kind of thing. And elective operation is the only way to do this. There's no such thing as an emergency ROS. This is something that you got to plan ahead of time and know that that's what's going to go on. It's something that not everyone knows how to do, so you've got to have the appropriate abilities available. Next.
Dr. Stelzer, this is Adam again. When you talk about the appropriate surgical talent available, and you reference surgeons who have the capabilities and skill sets to perform a ROS procedure, I guess a question, I know what I went through when I was evaluating this procedure was, is this a commonly performed? Do many surgeons know how to do this, or do you need to take the time as a patient to find those surgeons who are really dedicated to not only learning the technique but then mastering it?
This is a special operation, no question about it. It's not something that, as I say, don't try this at home. It's something that takes, I call it a three-dimensional thinking mindset. It's more akin to the congenital heart surgery world. And it's not surprising to me that congenital heart surgeons do this operation more frequently than adult heart surgeons. The bread and butter of adult heart surgery for many years was coronary bypass surgery. And there isn't anything particularly three-dimensional about that at all. And a standard simple tissue valve implantation or mechanical valve also doesn't require any three-dimensional thinking. If you take a valve off the shelf that's been factory tested to hold water, all you've got to do is sew it in without ripping it up, and it's going to work. But the pulmonary autograft, harvesting that from the right ventricular outflow tract is very unique to this operation. And putting it in, how you do that influences not only whether you bleed to death or whether it actually works. So, yeah, it does take a lot of, shall I say, experience and appropriate training to be able to do that operation. And so if a patient is interested in doing that, looking for potential candidates for a surgeon who has that kind of experience is one of the advantages of something that like Adam has on the website. He's got a lot of potential resources there for how you can find someone that's in your part of the world that may be able to help you. And I think it's worth the trouble. If you want to have the operation, then it's worth you going to the trouble to find someone that knows how to do it.
Great, thanks.
Sure. So there's some positive things, there's some potential negative things. The blood flow characteristics we call hemodynamics are just unmatched. It's hard to beat the original equipment. The other thing that Sir Magda Yacoub talks about in England is the advantages of having living tissue in your aortic valve. Living things do things that dead things don't. One of the things that he talks about is the biological feedback that living cells talk to other cells in their neighborhood. The influence on the coronary blood flow, the influence on how the whole aortic root works, is something that's a dynamic concert of living cells talking to each other. And the only way to have that absolutely normal is to have a living aortic valve. And the Ross is the only replacement valve that's alive. The lifestyle that you get as a result of not having to have blood thinners and having excellent blood flow is that you can do pretty much whatever you want. The only thing I tell people not to do is Olympic weightlifting. That's just a little bit strenuous on that little valve and puts a little more stress on the walls than you'd like to have. But if you want to do a triathlon, climb Mount McKinley or whatever you want, you can learn how to do that safely. There's certainly the potential for more than 20 years of lifestyle, whatever you want to do with this operation without having another operation. I would caution that the potential doesn't mean it's a guarantee that that's going to happen. But you don't even have the potential for that without a reoperation in an animal tissue valve. It just isn't going to happen. Next.
And Dr. Stelzer, we have a question from Sharon Barris on this topic. She writes in, as a 20-year Ross procedure recipient, what is the longest patient that you know of, and how long do you anticipate a patient can live without an aortic pulmonary valve replacement?
The longest one that I know of is one from England that was over 40 years. I think it was 42.
Wow.
And that's again, it's that things that can last that long have to be alive to do it.
Great. Mm-hmm. Thanks.
Well, what about things that might not be so easy about this? As we were implying, talking about Adam's question, the complexity of the double valve, actually double root procedure that this involves is more challenging. There have been concerns about the literally mortality risk of doing a more extensive operation, and that's the chances of you not making it out of the hospital alive. It's what we call operative mortality. And that has been reported in different series all the way from 1% to 6%. Well, 1% is pretty typical for aortic valve, 1% or less, but 6% is kind of out of hand. So, again, it depends on the experience of the operative team. There's been questions raised about its suitability in patients with bicuspid valve disease, and that has reared its ugly head again recently. But the question is because bicuspid valve patients tend to have weaker elastic tissue in the wall of the aorta. So there's a greater tendency for the aorta to stretch or time, to form an aneurysm, or even to have an aortic dissection at some point. Doesn't happen to everybody, but probably happens to at least 20%. So the question is validly raised to say, well, should you put a pulmonary valve into the aortic position if that pulmonary artery wall has the same potential to dilate that the aorta does in a patient with bicuspid valve disease? And I think the response to that is you can either quit doing the operation or you can learn how to do it better. And I chose the second alternative. So the consequences of a patient who has a Ross is that the root can dilate. And that's something that we do a lot of things now that we didn't do 25 years ago to prevent that from happening. Well, you've also introduced something on the right side of the heart. You've put a pulmonary homograft, a single donor low mileage valve, as I call it, donor valve that's now in the position where the pulmonary autograft used to be. Well, that can degenerate too, can it? I said, yeah, I certainly can. So you have a potential for trouble on the right side of the heart Now you've changed a single valve disease into a double valve disease. And that's a potential objection that's been raised by a number of people, particularly surgeons who don't do the Ross operation. And it's something that deserves respect, but I thought it was going to be a bigger problem than it turned out to be. And we'll talk about that a little bit more, and why I don't think that's so much of a problem. Risks at reoperation are also something that are different depending on what was done the first time. And when you've done a Ross operation the first time, there's a lot more redecoration having been done in there that can cause some scar tissue that can be challenging to getting at it to do any further surgery. But as long as you know what you did the first time, it's pretty easy to do it the second time in most patients. But it is more difficult, no question about it. Any reoperation is more difficult than the first one. I think I have a slide coming that talks about that. Next. But this is kind of a picture, artist rendition, and surgical picture of what the Ross looks like. And the one key point when you look on the right, you see the homograft is the prominent structure of the suture line on the right ventricular outflow tract. You don't see the other end of it because it's kind of buried up there on the top. And on the left side, you see the the right atrial appendage kind of peeking over the aorta, and you get a little bit of a hint of a coronary implant button, but you really can't see the business end of that where you attach that to the annulus. It's just buried under there. Next. And this is my personal experience since March of 1987 of 540 people. As you can see, it's about 3 to 1 men to women. The average age in this group is 43. It's a wide range, but the vast majority of them are in the middle of that, from the 20s to 50 range. Next. And as I say, there are only two kinds of patients, the kind that have complications and the kind that don't operate. So early on, I lost some patients. I lost 6 people. 3 of those were due to bleeding, and the various other ones for the other 3. I think some of that was learning how to do it. When you see what the learning curve looks like, I've been able to do a whole bunch of them. I didn't update that 295 in a row to the right number, but it's over 300 in a row without a death. Is the reason I can tell people that if I sit in the office and talk to you about surgery, I can do it for a very low mortality rate. The other thing that's very interesting, that one of our medical students did a survey with the Social Security Death Index, which is a way of finding out whether people are alive or not. And looking at all the patients that I had done that I had Social Security numbers on, we could look up and see whether any of these had died. And at 15 years, we had a survival of 93%. I think that's pretty respectable. Next. What are these people doing? These people are doing some pretty amazing things. Stunt pilots, champion bicycle racers, endurance sports, including Ironman, triathlon. It's pretty amazing. It's something that is a real joy to be able to give people their life back. Next.
And Dr. Stelzer, it's Adam again. Just one quick question. When a patient comes to you and they have a Ross procedure and they see you after the procedure, they come back to you 3 weeks later and they're feeling good, and they ask you the question, is there anything that I can't do now that I could do before the procedure? What is your response to them?
Well, those first few weeks after surgery are a special time. We want to have that new valve really delicately treated for the first several months. Some people say 3 months, some 6, some people say a year. Keep the blood pressure down nice and low so that the pulmonary valve can literally adapt to become an aortic valve. And it does change. That's what living things do. They'll adapt, and that's been demonstrated histologically, that pulmonary autograft becomes a very different valve in the aortic position over time. But if you beat up on it prematurely by letting your blood pressure go through the roof or trying to do these heavy weightlifting things, that can hurt it. So we discourage that. You also have to let your breastbone heal. That's something that people will regret if they try to lift heavy stuff within the first few weeks after surgery or fall off their bike. So be careful until that breastbone is solidly healed.
And then over time, a year, 2 years after the procedure, is there any physical activity that you would restrict your patients from participating in?
I really don't think there should be any restriction. With that one possible exception of the Olympic weightlifting. If you want to do bodybuilding, do more repetitions of lighter weights. But if you want to do other strenuous things like mountain bike racing, you name it, that should be very possible for you.
Great.
So the reasons that someone might choose a Ross in the current era, no blood thinners. Of all the reasons people come to me for this operation, that's the top of the list. The noise that's made by a mechanical valve is annoying. People say they get used to it. I've taken out at least 7 mechanical valves to put a Ross in patients, and they've all said it's really nice to not have to listen to that anymore. But okay, there are things you can get used to. The normal blood flow that influences things like coronary flow and talks to other cells around it, that's a key advantage over the long term. And the fact that you can do whatever you want in life is also a great thing. At the bottom I put here, so that was the quality stuff of life, but what about length of life? If that 93% at 15 years didn't sound good to you, let me tell you that the normal life expectancy of aortic valve replacement patients is 50% at 10 years. So why is that? Let's look at the next slide or two, because this is a message that the medical community has not really heard. This is Sir Magda Yacoub, who is acknowledged as the greatest surgeon in Great Britain living today. And he did a randomized controlled trial. Very few studies of that nature exist in cardiac surgery to say, how does one valve compare to another? We're going to have people that are candidates for either, and we're going to flip a coin to see which one you get. So he did this to a group of patients, 108 in each group, and at 10 years, they compared Ross patients versus patients who had an aortic homograft, both put in as root replacements. Why do you use a comparator of a homograft? Well, he did that because it was the best available tissue valve, better than the animal tissue valves. And doing it as a full root gave it the best hemodynamics. And at 10 years, there was a significant difference in the survival of the Ross patients over the homograft patients. So they came out on top, not just with doing better, but living longer. And he felt that it was the living valve that explained that. This was published in the Lancet, which is sort of the New England Journal of England, the Old England Journal, you might call it. And that was really what I call a landmark publication. In the next slide, there's a survival curve from that paper. And the Ross patients are on the top, where there's a dark line and a green line, and the homograft patients are on the dashed red line. What's the straight line up there is what we call the control population. That's the matched patients of same age and gender that were compared to the Ross patients. And you can see that the Ross patients are on the same survival curve as a normal patient. But the tissue valve, best available tissue valve, the homograft, was not. And that difference was statistically significant. And that's something that's a pretty impressive finding when done in a randomized prospective controlled trial. Next. So that just tells you the structure of the trial, and it kind of tells you that these were the kind of people we're talking about. The patients, 44% of them were between the ages of 21 and 34, 36% of them between the ages of 35 and 50. So these are the very age groups where tissue valves have their greatest challenges, and these are the people most likely to get a mechanical valve in the past, with that slide of all the different troubles that you can get to that we showed earlier. Next. And this is a very interesting thing. On the title of this paper in The Lancet is the little symbol up there in the upper left-hand corner. That's a symbol put in there by the editor of the journal that said, this is a paper that's so significant that your practice should be affected. Like, you should be doing something different if you're not doing this. But it hasn't changed anybody. Why? Next. Because there's been a lot of negative press. And people talk about how the operation takes too long, there's too much risk, there's the two-valve business, not everybody can do it, and you can't do it through a keyhole. You know, it's very, very fashionable to do very minimally invasive surgery these days, and this is not minimally invasive surgery. And they talk about how there's a very high rate, very high chance that you're going to have a reoperation, and it's going to be risky when you do that. This has been predicted by some real leaders in the field of cardiac surgery, but has not been proven by data. Next. And what about those reoperations? Well, if you put in an animal tissue valve, they're pretty much inevitable. And the risk of the mortality may be 1% at the first operation, and we usually say it's about double that at the second. In the days when the original operation was 5% and the redo was 10%, that's why it was reasonable to put in a mechanical valve that had a 15% chance of trouble by 20 years. But now those risks have gone down. That's one of the reasons we do more tissue valves. But my estimate and that of others in the field is that about 20% of patients who've had a Ross operation will have either or both valves reoperated on or intervened upon within 20 years. That means that 80% of people will not. Sometimes we can repair the autograft in the aortic position. Sometimes we have to replace it. Is the risk at the reoperation high? As I say, it depends on how you approach that. And if that is high, how much higher? Next. This is the concern about dilatation that came to fore after we'd been doing this for a while. As I told you, Donald Ross put the autograft inside the aorta and closed the aorta over it. When I started doing them, I started doing them as the full root replacement. And little did we know that that tissue was going to stretch. And it stretches both into a bigger diameter and a longer conduit, as is shown in this picture that was 11 years out. I said, whoa, that doesn't look good. Notice that the inflow end of it, right where the coronary artery is coming out over there, that's not stretched because of that felt strip that I put in at the inflow end. Next. So that caused the valve to leak, caused it to have regurgitation, and we had to redo them. This is a table of patients of mine that have had to have further surgery. Most of them I've done. Some have been done elsewhere, and usually patients will call me or email me if something was going on. I wish they'd all send me an echo every year, but they don't. They're having too much fun, I guess. And the reasons for why we had to reoperate on them are in the tables underneath. Notice on the right side of the heart, the right ventricular outflow tract homografts, only 8 patients. The vast majority of troubles have been with the autograft. So I said, oh, I thought the homograft was going to be the big trouble. They are lasting just fine. Next. Oh yeah, I should mention all reoperations were successful. Nobody died at reoperation. And yet risks at reoperation are kind of go with the scar tissue between the ribs and the heart, and there's scar tissue between the pulmonary artery and the aorta. You don't go digging in that hole. Leave that alone. And there's some rules that you have to apply. Have a lot of respect for where the coronaries are, and there's also some things that can be done at the time that you do the operation in the first place to make any second intervention safer. Who knows? You might need a coronary bypass someday. or a mitral valve operation. And having a thorough operative report that tells exactly what you did, is when I'm long dead and gone, if you need another operation, I want the guy who has to go back in there to know what I did. So I found the best thing to do is to give the patient a copy of my operative report. Then you won't have to wonder whether you can track it down. Next. There was this paper from the Mayo Clinic in 2010 that talked about the high risk of reoperation, not the risk of having one, but the risk of doing it. And that patients need to be warned, is in their paper, that if you have a Ross operation someday, you may have this real hair-raising, scary operation that will be very, very difficult for you. In fact, they did an awfully good job of bailing these people out, but it wasn't easy. So they've said other options were easier to do over, and they're right about that. But I think that being such a fine institution, they were doing everybody's worst disasters. So I don't think it's necessarily generally applicable, and hasn't been the case in my own situation where I've reoperated on almost the same number that they have. And there's more in the next couple of slides that talk about other people's experience with that too, that you can peruse at your leisure. Next. This German-Dutch Ross registry just provides tremendous amount of data, and probably our best. And the freedom from reoperation, everything in there, just look that over. And also doing it more than one way. There's more than one way to do this and get good results. Next. This is the way I support it with the felt strips now, not just at the bottom, but at the top. Next. And also providing support all the way around by preserving some of the native sinus tissue to give you two walls instead of one to support that autograft wall from stretching. Next. Some patients have aneurysms and that wall's not any good, so I reinforce it with Dacron. Used to do it with this little sleeve with church windows cut out over it like this. Next. This is an autograft in place, and you can see some excess pulmonary artery on top of where the commissures come up, and I get rid of all that so that that can't stretch, and so that my felt ends up right top where that forceps is on the right-hand upper corner, right next to where the commissure is. I want the stitches to end up right on top of there to make sure that that line, a circle around there, is exactly where it's going to be forever. Next. So I trim that down, and if the aortic root was all dilated out with an aneurysm before, I've replaced the aorta above it with a graft, and I use some of that graft material to put these reinforcement strips on the outside. Next. Rebuild it kind of like a big sandwich. The inside is the autograft, then another strip of felt, then the native aortic wall, then the artificial graft material outside, and then sew that all to the distal aorta, which is now a graft as well. Next. Takes a while to reassemble all that, but when it's all together, you can see that that autograft is not going anywhere. The little fuzzy stuff in the front is around the right coronary where it exits. Next, the final picture, I think, of this patient. Her question when she came to me is, am I going to go alive back to my 2-year-old, my 4-year-old? The next year she said, can I run the New York City Marathon this year? Next. So what about that homograft? There were 8 people in there that had in my series a requirement to do something more about it. What do we do about that? Next. These pictures show the calcium deposits in the inflow end of the homograft, seriously constricting that. And what was done was it was stretched out with a balloon, and a stent was placed, and within that, 20 years after his Ross operation, he got his warranty renewed with a percutaneous melody valve right here at Mount Sinai. Next. And this is why. See the calcium on the bottom end of that? The leaflets actually look pretty decent, but the muscle that we used to sew it into the right particular outflow tract really scarred up and ended up calcifying. You can go back and replace it surgically, or next slide, you can do it as that previous one did with this cage and the balloon inflating a valve inside of that cage that does the whole thing. And my colleague, Dr. Love, is doing that here. My screen went out there for a second. People ask me about percutaneous valves, the TAVI or TAVR as it's called now, the transcutaneous aortic valve implant or replacement. Does that change how we think about these things? Well, it does in terms of the age. How low can you go on the age and think you're going to get away with a tissue valve strategy? If you can put a valve inside that valve percutaneously, then you can renew that warranty, can't you? Just like we did there with that homograft. This is a concept that's been demonstrated and done in Europe, and it's currently under study in the United States. So we can lower the age, assuming we can get that tissue valve in there in an adequate size. That's an important thing that you see down there. The size of the initial device is to keep greater than 19. I should probably modify that from recent information that says you got to be at least 23, or the valve that you put inside is not going to be as big as you think. And how many Mariashka dolls can you put together? How many times can you keep putting a valve inside a valve inside a valve? The other aspect of it is that you can't ignore what's happening to the aortic root or the ascending aorta. That, at this point, we can't intervene upon except with open surgery. So we want to make sure that we take care of that, which we didn't know 20 years ago. The durability data of the percutaneous valves is really not there. The only data we really have, a 5-year survival of 30%. That's because these really old, sick people that are getting those valves are not really a way of saying, how would it work in me if I'm 50? Could you do a TAVI in a patient who had a Ross? Well, we just showed you one on the right side of the heart, the pulmonary side. What about on the left side in the aortic position? I think it probably could be done, but it's never been done. Because of those strips of Teflon felt, you've got a landing zone that could perhaps hold the pressure of a self-expanding nitinol-based valve, but that's something that we'll have to wait for in the future. The key thing is to have established a root that won't dilate into an aneurysm. Then if the valve fails, that might be treated. At the present time, percutaneous valves are only used for stenosis and not for regurgitation. But again, in Europe, they have rescued some regurgitant valves, especially the valve-in-valve, and even a David procedure that failed has been treated successfully. That's a little more comparable, I think, to what a Ross procedure patient might be if in need of rescue. So it's tantalizing to think what might be possible. Next. These are just a couple of pictures of patients that might have difficult operations. On the right is a patient who had, I think, 3 homografts in the past in the aortic position, and it just turned a rock pile. And they put a TAVI inside that one. On the far left is a patient that I actually did the first 2 operations, and that homograft root that you can literally see outlined in calcium, I dug that out and switched him to a Ross 23 years after I put his homograft in. Next. So my final conclusion is that this operation should definitely be on the menu. Between the ages of 15 and 50, that's my current thinking and my mind of who should be considering an operation like this. That survival advantage of a living aortic valve is something that I don't think we should ignore. It is the most difficult of the options in terms of the technical ability to do it, but it is doable. Mechanical valves are the most durable, but you pay a price. That price is not that you have to have another operation, but it's the most likely of the options to cause a stroke in the course of the next 20 years. That's what I call a life-changing as opposed to a reoperation, life-changing experience. The animal tissue valves are going to fail early, and how many times you're going to have to go back in. The 20-year-old is going to need a zipper. The 50-year-old may be able to get a TAVI. So how long are those going to last? How many times it can be done? That's the unknown world. That may just about do it, Adam. Let's see whether they got anything else. Is that it?
Yeah, I think that is it, and that moves us
Wow.
on to that was fantastic, Dr. Stelzer. And we're
sorry, I was talking so fast. We had a lot of ground to cover.
yeah. Well, thank you so much. That was really excellent and really helpful. And we've got just a time for one or two questions here. But Lyle Roberts is on the phone call, and I know in the previous slide you just discussed the age range here. And Lyle has a question. He says, at age 64 with normal life expectancy, is the Ross procedure an acceptable option?
I've had that question asked me. And, you know, if I had a guy who said, look, my parents lived to be 100 and I want to do mountain climbing and triathlons and I'm 64 and I have stenosis and I'm in great shape and there's nothing wrong with my coronaries, my kidneys, my lungs, or my brain, can I have a Ross? And I'll say, yeah, sure you can. It can be done.
Great.
Is it going to be a major advantage over using a tissue valve strategy? Not as big as when you're 34 as when you're 64. But, you know, if you really want to put your valve to that kind of a hemodynamic test, there are very few things that can produce that kind of blood flow characteristics like the Ross can.
Great. Well, I hope that helped you, Lyle. And then we've got several more questions here, and this one comes in from Damien. And this I remember personally when I was evaluating Ross procedure surgeons, I had a question just like Damien. He says, in general, when deciding on a surgeon, on average, how many prior surgeries do you recommend that a surgeon conduct given the uniqueness of a Ross procedure?
That's an excellent question, and you look back at that learning curve of mine, most of my trouble was in the first 30 people. So I think that's sort of my minimum number to say experience, but it's not just Ross experience, and that's an important perspective. The Ross operation, especially the way I do it, is a root replacement. Aortic root replacements are done with other materials, with other devices. And so if you've had a lot of experience doing that kind of surgery, that really counts. But there is unique stuff that you have to put in a Ross, particularly harvesting the autograft from the pulmonary outflow tract. And that can be mastered. That's not the most difficult part of the operation, even though it may be the most intimidating to surgeons who've never done it. But that's something that can be taught. And then as long as you know how to use anything to replace the aortic root, the concepts are very similar. You just have to be much more gentle with that delicate tissue of the pulmonary autograft is pretty unforgiving if you're going rough and tough and tumble on that. You've got to be gentle. So you should talk to the surgeon's spouse and find out whether they're gentle or not.
Got it. Well, Dr. Stelzer, with that response, we are going to conclude the webinar. But please don't exit the webinar just yet. On behalf of the entire community here at HeartValveSurgery.com and all the patients with valve disease, I'd like to extend really an extraordinary thank you to Dr. Stelzer and his team at Mount Sinai for sharing this incredible expertise with everybody on the call today. What we're going to do is we're going to put together a video of this session. We're also going to put together a written transcript in the form of an ebook of everything you heard today on the webinar. It'll be posted at Heart Valve Surgery shortly. And as we end the webinar, I'd like to thank you, everybody on the call, for your participation in this really amazing online event. As we close, I'd like to ask you to complete a very, very quick 5-question survey that is about to appear on your screen. So Dr. Stelzer, one more time, thanks so much for being on the call.